Welcome to the deep dive. Today we're plunging into the pretty fascinating, sometimes dangerous world of decompression sickness, DCS.
That's right.
Might know it by its older names, like the
Right.
bends, the chokes.
The staggers hits.
Exactly. We've got a really detailed chapter as our source this time. It's kind of a deep dive within our deep dive, really.
It is pretty comprehensive.
It covers, well, everything from who's at risk to what exactly is going on inside your body when the pressure changes suddenly.
Yeah, it gives us that big picture of dispairism, basically. Any health issue caused by pressure changes. DCS is a big one, but there are others too.
Right.
And our mission today really is to help you get the core ideas, those sort of aha moments.
Without getting totally bogged down in the weeds.
Exactly. Get the surprising facts, understand the basics, but not feel overwhelmed.
Okay, let's unpack this then. First things first. What exactly is dispairism, and how does DCS fit in?
Well, think of dispairism as like an umbrella term. It's any pathological change that happens because the environmental pressure around you changes.
Okay.
DCS is one specific type under that umbrella, but you also have things like pulmonary barotrauma lung injury from pressure.
Right.
And aseptic bone necrosis, bone tissue death, something that's linked to decompression too.
Gotcha. So DCS is triggered by that pressure shift. What's actually happening? What causes, the bends?
It really boils down to a rapid drop in environmental pressure.
Okay.
So when you've been under higher pressure, gases dissolve into your tissues, mostly nitrogen, usually.
Or helium if you're using special mixes.
Exactly. Helium if you're on heliox. But when that pressure drops quickly, those dissolved gases become supersaturated.
Like shaking a soda can.
Precisely. You open it fast, bubbles come out. Same idea in the body, that supersaturation makes gas bubbles form in your tissues and blood.
In those old names, the bends, the chokes, they weren't just random, were they? They actually described symptoms.
They really do. The bends, that's usually joint pain, probably because gas forms in those dense connective tissues, tendons, ligaments.
Okay.
There's even radiographic evidence from aviators back in the day showing gas in knee ligaments after rapid decompression.
Wow. Okay.
The chokes, well, that points to lung symptoms, bubbles affecting pulmonary function.
Makes sense.
The staggers suggests vestibular problems, balance, vertigo, and hits was often used for spinal cord issues. So yeah, the names were quite descriptive.
So who's typically at risk? It's obviously divers.
Divers are a major group, yeah, usually within about 24 hours after ascending from, say, 6 meters or more.
But not just divers?
No, definitely not. Compressed air workers think tunnel construction, caissons.
Right.
And really, anyone who experiences a rapid drop in barometric pressure. So people in hyperbaric chambers, aircraft climbing fast over 5,000 meters.
Even astronauts?
Even astronauts doing spacewalks, yeah. And interestingly, there's some thought that bubble formation might even contribute to the type of acute mountain sickness climbers get with very rapid ascents.
Huh. That's much broader than I realized.
It is.
Now, you mentioned nitrogen dissolving. I saw this figure at sea level. We have almost a liter of nitrogen dissolved in us. That seems incredible.
It's true, and it's interesting where it goes. A bit less than half is in body water, but over half is actually in our fat tissue.
Really? Why fat?
Because nitrogen is about 5 times more soluble in fat than in water. And fat makes up, maybe 15% of a typical male body.
Oh, okay.
So the deeper you dive and the longer you stay down, the more nitrogen dissolves, especially in that fat.
How does that compare to using helium mixes?
It's different with helium. Helium's less soluble in fat, so less dissolves overall. Plus, if you switch back to breathing air, the helium gets eliminated pretty quickly.
Okay. And what about decompression tables? Divers rely on those, but the source mentioned Haldane's principle as, well, more of a guideline.
Yeah, the basis often goes back to Haldane noticing DCS was rare if you halved the absolute pressure, like going from 2 atmospheres down to 1.
Okay.
But even he warned about applying that rigidly above 6 atmospheres. And later work showed gas can form even with just a halving of pressure.
So the tables aren't foolproof?
Not entirely. Haldane's principle was foundational for sure, and it's still relevant for formulating tables. But it's an empirical guide, not a hard and fast law. You can't just say have the pressure and you're fine.
Right. Okay. So we've got gas dissolving, pressure dropping, bubbles forming.
Yeah.
What's the body's immediate reaction? Let's get into the pathophysiology.
Okay, so the body's primary way to get rid of that excess inert gas is transferring it from the blood to the air you breathe out in your lungs.
Makes sense.
But the exchange isn't perfect. There's something called ventilation-perfusion mismatch.
meaning blood flow and airflow aren't perfectly matched everywhere in the lungs.
Exactly. So some blood goes through without getting fully degassed, and that still supersaturated blood enters the general circulation. And, DCS can even happen after lots of repetitive breath hold dives.
Really?
Because the air in the lungs gets compressed, which increases the nitrogen pressure, driving it into the blood and tissues over time.
And can we actually see these bubbles forming?
We can, yeah. Using techniques like ultrasound, you can see this gas phase forming in tissues like muscle.
And it's mostly nitrogen or helium.
Primarily the inert diluent gas, yeah. But oxygen, CO2, water vapor, they all contribute to the bubble volume. And the current thinking involves these tiny, pre-existing gas nanobubbles.
Nanobubbles.
Yeah, tiny gas nuclei that are already there, potentially. And under the right conditions, they can enlarge very rapidly, acting like seeds for the bigger bubbles we detect.
Okay. And going back to the bends, that joint pain, what's the specific thinking there?
Well, a lot of evidence points to gas forming right within the dense connective tissue of tendons and ligaments.
Like those aviator x-rays you mentioned?
Exactly. And the way blood flows in these tissues, it's often intermittent. So gas gets taken up when blood flows, but if microcirculation shuts down during decompression,
The gas gets trapped.
it becomes harder for it to get out. It switches from being blood flow limited to diffusion limited. Plus, oxygen gets used up locally, which might effectively increase the relative amount of nitrogen there.
Interesting. What about bubbles in the blood vessels themselves? Intravascular bubbles.
Yeah, those are often detected usually in the pulmonary artery heading towards the lungs either during or after decompression.
When do they show up?
Depends on the dive. Like in a long heliox saturation dive, you might see them during the decompression phase. After a typical air dive, it's usually only after you've surfaced.
And I read something about a coating on these bubbles in fatal cases. That sounds bad.
It does. Electron microscopy shows this sort of osmophilic coating, basically a layer of material, maybe proteins or lipids, stuck to the bubble surface.
And that causes problems?
It seems to slow down nitrogen elimination as the bubbles get maybe stickier or less able to dissolve, especially when trapped in lung capillaries. Plus, the bubbles themselves damage blood vessel walls, making them leaky.
Leaky vessels. That leads to.
In severe cases, it can lead to hypovolemic shock, not enough fluid volume and blood sludging, where red cells clump up. And expanding gas in tissues can trigger the release of various bioactive substances.
So arterial bubbles are different.
Right. Bubbles forming directly in arteries usually only happen with very, very sudden decompression from high pressure. It's less common than venous bubbles.
So generally speaking, more gas means more severe DCS. What about exercise? Do you hear conflicting things?
It's a bit of a double-edged sword. Exercise can help eliminate dissolved gas overall,
Okay.
but it can also encourage gas to come out of solution in the tissues and form bubbles in the circulation.
So where do bubbles typically form first?
Usually on the venous side in the veins heading back to the heart and lungs.
And the lungs filter them out.
If there aren't too many, yes. The lungs are a pretty effective filter. But if the bubble load gets too high,
They can get through.
they can overwhelm the filter, pass through the pulmonary circulation, and enter the systemic arterial side.
And potentially go anywhere, like the brain or spinal cord.
Precisely. And there's also the issue of a patent foramen oval, or PFO.
That's the hole in the heart.
Yeah, a small opening between the heart's upper chambers that sometimes doesn't close fully after birth. It provides a potential shortcut for venous bubbles to bypass the lungs entirely and go straight into arterial circulation.
Making those people more susceptible.
Potentially, yes. Where bubbles form most readily also depends on things like how supersaturated the tissues are and the solubility of the gas. Finding bubbles inside cells is actually pretty rare, usually only in extreme experiments.
It's interesting how this differs from, say, military oxygen diving.
Right. With 100% oxygen, you don't get inert gas bubbles, but you trade that risk for the risk of acute oxygen toxicity.
Convulsions underwater.
Exactly. Which can obviously lead to drowning. And then you have recreational divers using nitrox oxygen-enriched air.
To reduce DCS risk, right?
Yeah, it can lower the nitrogen load and reduce the risk or allow longer bottom times. But it doesn't eliminate DCS risk completely, and you still have to be mindful of oxygen toxicity limits, hence things like full face masks in some technical diving.
Okay, let's shift focus a bit to specific organs. The source detailed pulmonary and neurological issues. What happens in the lungs?
Well, the very first ultrasound detection of decompression bubbles was actually in a pig's vena cava.
Huh.
Human studies, often using less sensitive Doppler detectors, show many divers have bubbles in their pulmonary artery post-dive, often without any symptoms at all.
So bubbles are common, symptoms aren't always.
Exactly. But experiments show that under high enough pressure gradients, venous bubbles can physically cross the lung filter. And there's even a theory that bubbles trapped during compression could cross later as they shrink.
You mentioned the chokes earlier being potentially fatal.
Before good decompression practices, yeah, pulmonary DCS was very serious. You get low blood oxygen, high pressure in the lung arteries, severe breathing difficulty.
Like other conditions with microemboli.
Yes, similar to fat embolism, it can lead to ARDS, acute respiratory distress syndrome. The main response seems to be a non-cardiac pulmonary edema fluid buildup not caused by heart failure, likely triggered by the sheer number of microbubbles hitting the lung circulation. Swelling around the airways can also occur.
And how is pulmonary barotrauma different? That's lung overpressure injury, right?
Correct. That's from gas expanding in the lungs during ascent, not bubbles forming from dissolved gas.
Okay.
If gas gets trapped, expanding air can rupture alveoli. This can force air into the bloodstream, causing arterial gas embolism.
Which is very serious.
Very. Or air can track into the chest cavity, causing emphysema or collapse along pneumothorax. It's more common in recreational divers, maybe due to panic, running out of air, leading to a rapid ascent. And if it happens at the end of a dive, you've got the barotrauma plus all that dissolved nitrogen.
A dangerous combination.
Oh.
Let's move to the CNS, the brain and spinal cord. The source contrasted big bubbles in gas embolism with the smaller DCS bubbles. Why does size matter so much?
Size is critical. Large bubbles, like in arterial gas embolism, can physically block larger vessels, causing immediate ischemia, lack of blood flow and oxygen.
Okay.
Decompression bubbles are typically much smaller, maybe around 25 micrometers. Their behavior is more like other microemboli, and their size changes with pressure too. A key factor in CNS injury and DCS is ischemic hypoxia, reduced oxygen due to impaired blood flow, even if it's not a complete blockage.
And neutrophils' immune cells get involved.
They do. Studies show hypoxia signals neutrophils early, and they seem to congregate around small veins, paravenular areas where DCS lesions often occur. You can even see these as bright spots on an MRI sometimes.
So it's not just blockage, but inflammation too.
Exactly.
Mm.
Gas bubbles, even small ones, can damage the endothelium, the vessel lining. In the brain, this can make the blood-brain barrier leaky.
The brain's border control.
Right. When it leaks, proteins get out, triggering inflammation via the complement system. This localized swelling, or edema, can then compress tiny capillaries, worsening the ischemia. It's a vicious cycle. Animal studies show bubbles appearing before detectable changes in brain electrical activity.
So the bubbles come first.
Seems that way. And that complement activation might even cause red blood cells to clump in severe shock cases. How well neurons recover depends a lot on these complex interactions between blood components and damaged tissue.
I was surprised fat embolism came up again here.
Yeah, it can be a consequence of decompression, sometimes severe. Fluid fat droplets can potentially squeeze through the lung filter and reach the brain.
And cause similar problems.
Yes, damage the blood-brain barrier, cause edema, inflammation, and lead to demyelination, stripping the insulation off nerve fibers sometimes, even while the nerve axon itself is okay initially.
The source also mentioned why white matter might be particularly vulnerable.
It has to do with its blood supply. White matter often relies on long draining veins with areas that have fewer capillaries. And because the gray matter is so metabolically active, using up lots of oxygen, the venous blood leaving it is already low in oxygen.
So white matter is starting at a disadvantage.
In a way. If microbubbles then further impair oxygen delivery, the white matter can hit critically low oxygen levels quickly. This triggers that whole cascade. Leaky barrier, inflammation, demyelination, axonal damage. Actually, features quite similar to early MS lesions.
And hyperbaric oxygen helps how?
Breathing oxygen under pressure is the main way to significantly boost oxygen levels in that venous blood and tissues, even though a big jump in arterial oxygen only gives a modest bump in venous oxygen.
It's enough to make a difference.
It's proven valuable, yeah, both in animal studies and clinically for restoring function in this perivenous-type injury common in DCS.
Now, there was another idea mentioned bubbles actually forming inside the white matter.
Botricthonus bubbles, yeah, forming in situ. This has been seen in animal experiments, particularly with rapid decompression, where bubbles nucleate within the myelin sheaths themselves. Yeah, they could directly damage neurons where they form and compress adjacent ones. This might explain some very abrupt symptom onsets, but the experimental conditions are often pretty extreme compared to typical human DCS.
Okay, let's focus on the spinal cord. Paraplegia is a major risk in diving DCS, but you said it's rare in altitude DCS.
That's right. Paraplegia is a really obvious, serious outcome in type 2 diving DCS, but much less common in hypobaric altitude-related DCS. It probably highlights differences in bubble size, gas loading, maybe other factors.
But divers with spinal issues often have brain symptoms too.
Often, yes. They might report confusion, visual disturbances, things like that, alongside the spinal symptoms.
And the proposed mechanisms for spinal cord injury.
Three main theories: arterial bubble embolism blocking supply, obstruction of the epidural veins around the cord causing backup and infarction, or those autoconthinous bubbles forming right in the cord tissue.
Was it initially hard to blame arterial embolism?
A bit, yeah, because there wasn't a well-recognized natural spinal cord disease caused by microemboli. But now, with ideas like MS potentially involving fat embolism, it's more accepted.
Interesting parallel with MS.
Yeah, both can have retinal changes. Spinal cord symptoms often dominate. DCS can cause transverse myelitis that can worsen later. Both can have cranial nerve issues or nystagmus.
So DCS can mimic other neurological conditions.
It definitely can.
How does the epidural vein blockage idea compare?
That typically causes infarction, tissue death more in the center of the cord. DCS lesions are often more focal, patchy, but gas or edema could still cause ischemia by raising pressure inside the tight confines of the spinal cord.
And that fibrocartilaginous embolism, material from spinal discs.
Yeah, that's another potential source of microemboli that's maybe been overlooked in DCL discussions, material from the disc nucleus pulposus getting into the circulation.
How does that happen?
It's debated, but systemic embolization can occur. There was a post-mortem finding of disc material in a cerebral artery. Like DCS bubbles, it might get systemic access via the lungs or a PFO. The lungs probably filter and size these emboli too. It's actually a known issue in veterinary medicine.
What about microscopic changes seen in animal spinal cords?
Severe experimental DCS can cause myelin sheaths to look widened and disrupted in a specific pattern. This could be from gas forming within the myelin, but edema can cause similar appearances, so it's not definitive proof of autochthonous bubbles.
And the concern about long-term damage, even without symptoms.
Yes, for people with repeated exposures, divers, compressed air workers, maybe even U-2 pilots. One long-term goat study was interesting, though.
What did it find?
Over 5 years, with various dive profiles, some goats getting DCS, they didn't find a strong link between exposure history or DCS episodes and detectable brain lesions on MRI or later pathology.
So maybe not as much cumulative damage as feared.
In that study, yes, for the brain. However, they did find spinal scarring specifically in the animals that had experienced spinal cord DCS, so damage can definitely occur and leave its mark.
Okay, moving to blood changes. Even an asymptomatic dive can affect platelets.
Apparently so. Circulating platelet counts can drop by up to a third in the 24 hours after a significant dive, even without symptoms.
Wow.
Also, a factor that activates smooth muscle can be released during decompression, potentially amplifying the effects of other substances involved in shock. And platelets themselves might become hypersticky in severe neurological DCS, maybe due to certain fatty acid metabolites.
Do platelets interact directly with bubbles?
They do. Electron microscopy shows platelets sticking to bubble surfaces, forming aggregates. This clumping could potentially slow down bubble resolution during treatment.
Let's touch on disparic osteonecrosis, Diane. Bone death.
Yeah, reported after hyperbaric exposures with bad decompression, most common in compressed air workers. The standard theory is bubbles blocking small end arteries in the bone.
But there's an alternative hypothesis.
There is. One idea is it's not direct bubble blockage. Researchers found bubbles in the fatty marrow of bones with fat and platelets stuck to them. They proposed that injured marrow fat cells might release liquid fat.
Causing fat embolism.
Exactly, leading to systemic fat embolism, release of clotting factors, other vasoactive stuff, maybe triggering intravascular coagulation and then bone necrosis, a more indirect route.
Interesting. And finally, under pathophysiology, what about free radicals?
Their role is getting more attention, especially in reperfusion injury damage when blood flow returns after being cut off. While blockage is maybe more typical of air embolism, DCS often involves leaky vessels and inflammation.
So how do free radicals fit into DCS?
One idea is a two-phase neurological injury. Phase 1 is the mechanical effect of bubbles on vessel walls. Phase 2 might involve oxygen-free radicals released by neutrophils invading the area in response to hypoxia.
Could the oxygen used in treatment contribute?
It's a consideration. Using 100% oxygen at 2.8 atmospheres for recompression can sometimes worsen symptoms or cause oxygen toxicity convulsions.
But convulsions aren't usually linked to lasting damage.
Generally not, no. They might even be related to low blood sugar from intense vasoconstriction, but despite that risk, rapid recompression is still paramount. Adding antioxidants in animal studies hasn't really improved outcomes in severe DCS.
Yeah, that's a lot on what happens. Let's talk about the clinical side. How does DCS actually present? How is it diagnosed?
Haldane's original classification is still useful. Type I is basically joint pain. Type 2 involves systemic issues, CNS, lungs, heart. Type 3 was convulsions death, thankfully rarer now.
So type I and 2 are the main ones seen.
Right. And DCS can hit various organs. Studies often show type I, the joint pain, as most common overall.
But it depends on the dive.
Absolutely. Mild joint pain might be common in, say, long heliox saturation decompressions, where type 2 is rare. But surface decompression diving, deeper air dives, you see more type 2 then. And, joint pain is often easier for someone to recognize than subtle neurological symptoms.
There was that skin sign mentioned, cutis marmorata.
Yeah, that mottled, blotchy rash. It's rare, but important because it can sometimes precede serious CNS involvement.
What causes it?
Theories range from brainstem bubbles affecting skin blood vessel control to just systemic microbubbles reaching the skin. Either way, seeing it means you need to carefully check for neurological signs. It also doesn't always respond that well to recompression.
What's the usual timing for symptoms after a dive?
For most standard dives, symptoms usually pop up within 3 hours of surfacing. But onset can be delayed 35 hours or even more, especially if flying is involved.
Wow, that long.
Yeah. And for air diving, almost half of the brain and spinal cases show up really fast within 3 minutes of surfacing.
Yikes.
The really serious stuff involves the CNS brain hemispheres, spinal cord, vestibular system causing balance issues, vertigo, hearing loss. Diving tends to hit the spinal cord more often. Altitude DCS often presents with more cerebral symptoms.
Which part of the spinal cord is most common?
Usually the lower thoracic region, but it can vary. CNS involvement happens in maybe a quarter of air diving DCS cases needing in-water stops. And frustratingly, function can deteriorate years later, or you can get acute brain issues, weakness, speech problems, vision loss, memory trouble, seizures.
What about those breath hold divers again? DCS there seems different.
It does seem to primarily affect the brain in those cases. MRI studies on Japanese AMA divers showed infarcts, like mini strokes, in watershed brain areas. And surveys found more stroke-like events, likely due to arterialized nitrogen bubbles getting through the lungs or heart.
Any other systems affected? Heart, lungs?
Occasionally cardiac arrhythmias, yeah. Pulmonary symptoms in maybe 2% of severe cases. That non-cardiogenic pulmonary edema we talked about can happen, usually within 6 hours post-dive. Shock is rare, but possible after very severe dives.
Okay, let's focus on altitude DCS for a moment. How does it compare symptom-wise?
Typically seen above 20,000 feet, but can occur lower, especially with risk factors. One case report was at only 8,000 feet. A U.S. Air Force review found the most common symptoms were joint pain, headache, visual issues, pins and needles, confusion. Spinal cord stuff, chokes, unconsciousness were rare. HBO treatment tends to be very successful with low residual problems.
But the symptoms can be varied and confusing.
Very. Nausea, headache, fatigue, breathing difficulty. It can mimic a viral illness, but if HBO resolves it, that points strongly to DCS.
And the key difference versus diving DCS?
Cerebral hypoxia, lack of oxygen to the brain, seems less of a primary feature in diving DCS, but plays a bigger role in altitude DCS. This might explain why brain symptoms are often more prominent and severe at altitude. Treatment is similar, though: immediate compression, oxygen. The USAF has specific protocols adapted from Navy tables.
Okay. And acute mountain sickness, AMS, is that related?
It's complicated. AMS happens above 3,000 meters without acclimatization, headache, nausea, dizziness, etc. Can progress to brain or lung edema.
Caused by low oxygen.
Cerebral edema is often blamed on hypoxic vasodilation, yeah. Pulmonary edema on capillary stress. But bubbles can't be totally ruled out as a contributor in some cases, especially with rapid ascent. Oxygen and descent are key treatments. Portable hyperbaric bags help too, though one study showed they mainly just delayed AMS onset.
What about space? DCS risk there.
Definitely a risk during spacewalks because of the lower suit pressure. Losing suit pressure is an emergency requiring immediate recompression. The ISS has hyperbaric capability for this.
Yeah, and eye problems, you said they're rare.
Very rare. Things like bubbles may be contributing to vitreal separation, retinal vein occlusion, visual impairment that improves with HBO, optic disc swelling. One pilot had suspected altitude DCS causing optic nerve head swelling, likely from microbubbles, but recovered fully with HBO. Choroidal ischemia, central serous chorioretinopathy have also been reported in aviators, possibly linked.
So diagnosis seems really dependent on the history and symptoms. Are tests useful?
History and clinical picture are paramount, absolutely. If there was a significant pressure exposure, you have to suspect DCS first. Recompression itself can be diagnostic, especially if pain resolves quickly with pressure.
But less clear for CNS symptoms.
Harder to tell if improvement is from shrinking bubbles or just the high oxygen helping with edema and hypoxia. General lab tests, not really helpful for diagnosis.
What about specific blood tests or imaging?
Low serum albumin, if present, might predict neurological DCS in divers, but it's not routine. Clotting tests aren't specific. Ultrasound bubble detection hasn't panned out for predicting neurological DCS, though MRI of bone marrow might predict future bone necrosis risk. Bone scans may be positive early for joint pain but don't correlate well. X-rays, useless acutely for bone necrosis. Retinal angiography, used in animals to see bubbles but not practical clinically.
So imaging is mainly MRI.
MRI is the most useful imaging, yeah. Better soft tissue detail than CT. It can show spinal cord or brain lesions after diving, helps in follow-up, or diagnosing atypical cases. But clinical correlation isn't always straightforward, similar to findings in compressed air workers or pilots. Electrophysiology like EEG or evoked potentials can sometimes help monitor treatment or detect spinal involvement. And neurosync testing isn't for acute diagnosis, but can track cognitive recovery later.
Okay, so suspicion is high, DCS is likely. What's the treatment approach?
First steps are critical, especially if you're unsure if it's DCS or air embolism from a rapid ascent.
Which can happen in recreational diving.
Exactly. But the initial management is the same. ABCs: airway, breathing, circulation, CPR if needed, then 100% oxygen as soon as possible, and get the person to a recompression chamber. Dan, the Diver Alert Network, is a great resource for advice.
What are the goals of putting someone in a chamber?
Main goals: shrink the bubbles physically with pressure, help the gas redissolve, and deliver high levels of oxygen to combat hypoxia and reduce swelling.
How quickly does it work for simple joint pain type I?
Usually very quickly with prompt recompression. Sometimes a brief worsening of pain initially, but often improves just with surface oxygen too. The key is making sure no neurological symptoms are hiding.
Because pain can mask them.
Right. A good neurological exam can be tough if someone's in a lot of pain. Surface oxygen is always valuable, but needs a good mask seal. Fluids are good too, high V if needed, but recompression is the definitive treatment.
Using oxygen typically.
Standard practice now is recompression to 2.8 atmospheres absolute, ATA, breathing oxygen, based on U.S. Navy Tables 5 and 6. This pressure reduces bubble volume significantly and fights the ischemia. You can't go much higher with pure oxygen due to toxicity risks.
So table 5 versus table 6.
Table 5 is shorter, used to be for simple type I pain only, but many places now just go straight to table 6.
Why the change?
Higher relapse rates with table 5 and the risk of missing subtle neurological stuff. Table 6 is longer, involves oxygen periods at 2.8 ATA, then a longer period at 1.9 ATA. If pain doesn't ease quickly on oxygen at 2.8 APA, you definitely use table 6. There are other protocols too, like COMEX 30, sometimes using helium oxygen.
What about treating altitude DCS? Is it the same?
Generally treated similarly with hyperbaric therapy. But the USEF has developed specific, sometimes shorter, protocols like treatment table 8 using oxygen at 2 ATA. It's shown some success, but needs more study.
And for neurological DCS, especially spinal cord, any special considerations?
Response depends on the injury type. Rapid onset cases might have more direct damage, fare worse, need more treatment. Later onset, more ischemia-driven cases might respond better to HBO. MRI doesn't always track clinical progress perfectly.
Is HBO better than just air compression for spinal DCS?
Studies show HBO is more effective, yes. And helium-oxygen mixtures are often used, especially in commercial diving or if initial oxygen treatment doesn't work well. Helium helps flush out nitrogen faster.
Even for air diving DCS?
Yes, there's good experience using Heliox successfully, even after air dives, sometimes after initial oxygen treatment failed. HBO at lower pressures, like to ATA can also be part of ongoing treatment for residual issues. Delay definitely worsens outcomes for severe spinal injuries.
What about inner ear problems?
Less common in air diving, more so with mixed gas switches. Hard to distinguish from barotrauma sometimes, but if it is DCS, immediate HBO offers the best chance for hearing recovery. Vasodilators, anti-inflammatories might also be used.
And facial baroparesis, nerve palsy.
That's usually a pressure-related nerve issue from poor eustachian tube function, not true DCS. Important to differentiate so you don't overtreat with long recompressions. HBO might help, as it does for Bell's palsy.
Are there long-term consequences of DCS?
Unfortunately, yes. Persistent pain, that bone necrosis, Dion. Motor problems, nerve damage, maybe higher vascular disease risk, cognitive deficits. It's a serious business.
Does the type of chamber matter? Monoplace versus multiplace?
Most dive facilities use multiplace chambers, allowing attendants inside. Monoplace chambers are debated for DCS, can't examine the patient easily, pressure limits might be lower, but if it's the only option, you use it. They should ideally be set up to allow air breaks for following standard tables.
What about oxygen versus other gases like heliox during treatment?
Oxygen is standard but has that 2.8 ATA toxicity limit and requires air breaks. Heliox allows deeper compression if needed and avoids adding nitrogen. It's essential for treating DCS after heliox dives to avoid counter-diffusion problems. Commercial diving has lots of experience using heliox effectively for both air and heliox DCS, often with better results than oxygen alone, especially for severe neurological cases. The U.S. Navy now includes heliox procedures too.
Any role for drugs?
Primarily supportive. 4 fluids are key for hydration in type 2, no established drug for type pain. Lots of experimental stuff looked at perfluorocarbons, steroids, lidocaine, anhedonors, anti-inflammatories, even antidepressants like fluoxetine in animal models, platelet inhibitors maybe, but none are standard practice. Recompression remains the cornerstone.
And the timing of treatment is crucial.
Absolutely critical. Early treatment dramatically improves outcomes, reduces long-term problems. That's why military and commercial diving often have good results, rapid access to treatment. Even delayed cases can benefit from HBO, sometimes days or weeks later. Observation after treatment is also important due to relapse risk. Transportable chambers can help bridge the gap in remote areas. Air travel after DCS is risky due to altitude effects.
And that's SPECT imaging for residual problems.
Yes. HMPAO SPECT brain scans can help identify areas of reduced blood flow, hypoperfusion, due to edema in patients with lingering neurological issues. Guiding further tailing HBO treatments at lower pressures seems to help some patients by reducing swelling, even if the initial bubbles are long gone.
Okay, let's wrap up with risk factors and prevention. What makes someone more likely to get DCS?
Several things. Obesity is a big one. Maybe gender, especially during menstruation for altitude DCS, though data conflicts. Genetic factors like complement sensitivity, high cholesterol. A patent foramen oval, PFO, is a major one.
The heart defect.
Right. Also, dive profile matters. Long bottom times, rapid ascent, deep dives, especially below 30 meters on air, heavy exercise during or after the dive, flying too soon after diving, dehydration, maybe even things like Viagra based on animal studies. Smoking's role is uncertain.
How can people minimize their risk?
Careful planning and execution of dives according to established decompression tables or dive computers is key. Slow, controlled ascents are vital. Remember, the tables are guides, not guarantees. Pre-dive conditioning, like hydration and maybe specific exercise, might help. Divers with unexplained serious neurological DCS should probably get checked for a PFO. If you have a known PFO and a history of DCS, stopping diving is usually advised.
What's the typical prognosis after DCS?
Depends heavily on the severity, especially neurological severity at onset. Prompt treatment helps, but doesn't guarantee full recovery in severe cases. Later presentations don't necessarily mean worse outcomes, but response to initial treatment is often predictive. Inner ear DCS and recreational divers can have poorer outcomes, unfortunately.
So, summing it all up, the key takeaways.
Okay, so air diving deep, past 30 meters, really bumps up the risk. Following tables helps, but isn't foolproof. Early recognition and treatment are absolutely essential. Get oxygen, get to a chamber. Recompression with high-pressure oxygen is the first line. Heliox mixtures are valuable, especially for neurological DCS or when initial treatment isn't enough. And finally, good diving practices and knowing the risk factors are your best bet for prevention.
Right. So, to recap our deep dive, DCS is caused by gas bubbles forming from pressure changes, manifesting in diverse ways. Early recompression is key. Risk factors are varied.
And research is ongoing, looking for better treatments, better protocols, especially for tricky situations like altitude DCS.
It really makes you think, doesn't it? This complex dance between our physiology and extreme environments, microscopic bubbles causing potentially massive problems. What does it tell us about pushing human limits, not just underwater, but in the air and even into space? Something to ponder. Thanks for joining us on this deep dive today. Definitely check out the source if you want more detail, and feel free to send us your own sources for future explorations.